Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. An interview with Tom Hill, National Council for Behavioral Health. What brought you into the recovery field?
I got into recovery in 1992. I was living in New York City. And one of the things that I did in early recovery was I came to terms with my sexual orientation and started telling the truth about that to everyone. And I loved coming out so much that I decided to come out twice because I did not want to keep my recovery a secret. And there were some ramifications with that. But I didn't realize it at the time, and so I just sort of plundered ahead stupidly, but boldly, and I've never known any better. So I've always been very open. I've always thought people saw me in active addiction. Why would I want them not to see me in recovery? And that was how I thought at the time. But over the years, it's gotten better. But initially, when I even disclosed my recovery status to people in the field, they would take a step back. And so I felt that stigma very early on about what you talked about and what you didn't talk about. And so, I've learned a lot about recovery since. I do a lot of recovery work, and I've been really fortunate to be able to do that. And I've seen stigma in a lot of places. And I've sort of come to the conclusion that if stigma didn't exist, this addiction problem wouldn't exist, not the way that we're trying to solve it. We've created our own problem in a lot of ways, and it's been years and decades of not talking about what needs to be talked about or using the wrong terminology, really looking at addiction as shame and blame rather than as a chronic brain disease as we know it is now. We didn't always know that, so it's nobody's fault. But we're caught in this bind right now where we know a certain thing, but we act in a very different way. So things like words like substance abuse, right? So hard to get out of our lexicon. Many of our institutions are named substance abuse. SAMHSA is named substance abuse. It takes an act of Congress to change that. It will be changed. It may take a while, but it's going to be changed because people know now. We have research that says when you refer to something as abuse or you refer to people as abusers, that is a very stigmatizing way to look at a medical issue, right? So, in my early recovery, if I had known about trauma, if I had known about what trauma, I knew about trauma, but I didn't have a framework for it. And when I learned about ACEs, the adverse childhood experiences, it opened up a whole way for me to understand my history and my addiction and my recovery. And so, we blame people for becoming addicted. But if you look at the ACEs studies, ACEs was a study done by the CDC and Kaiser in the late 90s. And it had a scale of 10 different things. Things like observed violence in the home, had a mother or father or adult that was drinking or using drugs, had somebody in the family that was incarcerated. And it's a 10-point scale. And when I took that and came up with 7 out of 10, and it was like everything made sense to me. So I talk about the ACEs study because when you talk about people with histories of trauma affects the brain in a very similar way that substances affect the brain. It changes the structure of the brain. And for many people with trauma, to use substances helps that structure of the brain, at least initially. It doesn't in the long term, but it's I guess a form of self-medication. I never thought of it that way. I just thought if I used alcohol and other drugs, I felt normal. And so, when we point fingers at people and say, I didn't put a needle in your arm, you chose to do that yourself. I'm not sure that we've had that choice. we also live in a society where it's okay to go to a cocktail party, but it's not okay to smoke pot or to shoot heroin. It's okay to go to a cocktail party as long as you contain your drinking and don't become alcoholic in your drinking. But who knows where that line is? And who has the power to point the finger to somebody and say, you brought this on yourself? Well, I know I didn't bring it on myself. And I talk to people in recovery all over this country, and I know they didn't bring it on themselves. And I think we're all learning that. But we still act as if we want to point blame to somebody. And that may be a societal ill. I don't know. I just know that this is not something that we can solve by blaming or shaming. We have to say, these people have a disease or a sickness or a chronic condition like any other, and that we need to help them get well. And that's a very different way of looking at things. But we've carved ourselves into a corner by our own attitudes and a really outdated belief system. And guess what, folks? It ain't working. In fact, it's causing more harm than good. So, I've overcome that. I know other people that have overcome that. But I know for folks that are still in the throes of addiction and don't know what to do with it, it's a barrier. It's a barrier to get help. It's a barrier to admit that I have a problem. And I would like to say that it's not an individual problem, it's a societal problem. And we're going to have to solve this as a society. So we have a very great imperative in front of us right now. We have an opioid epidemic that's really an addiction epidemic. We know it's not just about opioids. We know it's about marijuana, it's about methamphetamine, it's about alcohol. We know that long-term, it's not just one substance out there. But we know that folks are committing suicide at higher rates. They're becoming addicted at higher rates. We have depression and anxiety at higher rates. This is a societal problem we're dealing with right now. And so we have to look at it with a very clear lens and say, how do we help these people? How do we help ourselves? And how do we help individuals, families, communities, and the entire society in terms of getting better? Because we're not better. We are all very, very sick.
Why do you think individuals with significant trauma in their lives have a high chance of being involved in the criminal justice system?
If you have a high ACEs score, you're not only prone to chronic conditions, a shorter lifespan, but you're also prone to greater rates of incarceration. A lot of things you're prone to. So a lot of folks in the correctional system have very high ACEs scores, or maybe have trauma from somewhere else. Maybe they've served in combat. Maybe they've witnessed traumatic events in their lives. Maybe they have intergenerational or cultural trauma. Trauma is pretty pervasive, and we haven't paid much attention to it. So the way we treat people in the correction system, we call them offenders. We point a lot of fingers at shame and blame. We often have not dealt with people as human beings. And so I think, we have an opportunity to change that as well. There's another area, the idea of medications. We have 3 FDA-approved medications. 2 of them are agonist or partial agonist, meaning that they have some opioids in them. And we have some very outdated beliefs about those medications, from providers to corrections people, to the recovery community. I mean, it's everywhere. And so we have this idea that because they are opioid-based, that people are getting high, that they're cheating recovery, that we call it drug replacement therapy. We have a lot of attitudes that are embedded in our language, but also embedded in our belief system. And it really is a deterrent on many, many levels. All those levels I just named, it's a deterrent for people to get better. So we have this, it's almost a superstition about, methadone, buprenorphine, like you're getting high. The bottom line is, if somebody is taking them as prescribed by a doctor, dosed by a doctor, figuring out how to incorporate that in their lives, if they're doing that and they're not getting high, excuse me, they're not using any form of mind-altering drug, like heroin, like Oxycontin, like methamphetamine, like marijuana, like alcohol. They're just doing their medication. Guess what? They're practicing abstinence-based recovery. And even our language around that is really misguided because we say medication-assisted treatment versus abstinence-based recovery, and the two are not mutually exclusive. I know hundreds and hundreds of people on medication-assisted therapy that are practicing abstinence-based recovery, and we need to start talking that language as well because we're doing ourselves a disservice if we're pitting these two things as mutually exclusive things and opposing forces when they can actually coexist in a person's reality.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.